Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 119, Belly Woman. So I'm very excited to welcome today Benjamin Black, author of Belly Woman, an absolutely fascinating book. Benjamin is a consultant obstetrician and gynecologist in the UK, but also works for Médecins Sans Frontières. Benjamin, perhaps you would like to tell us a little bit more about yourself.
Great. Well, thank you very much for having me. So I'm a consultant obstetrician gynecologist, and I split my time between working, as you said, for the medical aid organisation, MSF, also known as Médecins Sans Frontières, or Doctors Without Borders, and in the UK as a clinician working in London. My background is that I trained obviously in obs and gynae, but also a little bit more broadly in sexual reproductive health, including contraception and abortion care, and the wider spectrum of care that's required when working in the humanitarian sector. And over the course of my training and throughout my career, I've been going out to the humanitarian field, working in different locations of either epidemics, conflicts, or displacement, and have studied alongside that in political economy of conflict to try and back that up. And I've, as you said, just about to publish a book recounting some of those experiences, particularly focused on the West African Ebola epidemic and the impact it had on pregnant women and reproductive health care.
So I was interested at the beginning when I was reading your book that you were saying your interest was kind of humanitarian medicine, and then you went into obs and gynae. Because I'd kind of imagined it would be the other way around, that you'd be doing obs and gynae and then you'd think humanitarian. So, but you've just explained you've done quite a lot of other things around the obs and gynae. That sounds quite challenging. Yeah, no,
I always knew that I wanted to work in humanitarian assistance since school age. And, as is often the case with many people, I sort of sat down with a careers counsellor at some point around GCSEs. And they looked a bit confused by my aspirations and said, "Well, you should probably do medicine," and so that was the advice I took. In retrospect, I think there's lots of ways that you can work in humanitarian assistance. Whether that's through social sciences, politics, economics, policy, and medicine is sort of. I think medicine is something that people think of a lot because that's what they often hear about and see on the TV, but it's not necessarily the nuts and bolts of humanitarian aid in practice. But that's what I did. And I was thinking around, which specialties I wanted to work with. And it was when I went to work for a little while on the border between Thailand and Myanmar or Burma with refugees there. And it was during that time that I had exposure to the very real impact that conflict and displacement has on reproductive health, and seeing the spectrum of what we can offer as obstetricians and gynecologists, as we do in the UK as well, that we have those skills of surgery, of medicine, of women's health, of newborn health, that there's a strong public health element to it. There's a strong communication element to it. For me, it encompassed such a broad breadth of disciplines that it made perfect sense that this would be the direction that I would go. And also because I hadn't, perhaps naively, but I hadn't appreciated just how vast the needs were within reproductive health, within conflict and humanitarian settings. And so it really spoke to me.
I'm very in awe of you because I have this kind of aspiration that I would like to go and do some sort of medical work abroad. And early in my career, when I explored it, people kind of said, no, they don't want people that are very junior. They want people that are really experienced. And then I got bogged down with life like you do. So, you know, I was married, I had small children, and I couldn't do it. And now I'm coming out the other end and my kids are growing up. I'm thinking about it again. So to manage to do it at sort of all the different stages of your career and combine the two, I'm just wondering how you managed to do that, particularly now there's run-through training for specialty trainees. They've got to start at the beginning and do their 7 years. It seems quite inflexible. So how do you juggle that?
Yeah, so I was quite fortunate. I took gaps before I entered obs and gynae training, and I also took 2 years out of training after ST5. So and that was with MSF. So for MSF in general, they want someone who is at senior registrar or consultant level, because once you go out to the field, you might be the only person providing obs and gynae level care. So you're not necessarily going to have that backup that you have in the UK as a more junior doctor to call someone else to help you in the theatre. And you know, as you've read the book, you'll know that that's exactly sort of what happened to me in my
Yes.
first shift, that I found myself in a situation that I would normally be calling every other obs and gynae that I know, but I had to get on with it and deal with it myself, and so that's really important. But I did manage to take those sort of longer breaks during my training, and then whilst I was in the UK working, I managed to continue to be engaged. I think it's really worth sort of pointing out that the world's quite different now, and you don't need to go to Somalia to be engaged in a humanitarian response. You can be supporting from the UK through telemedicine platforms, through writing and supporting training activities, and also, you know, advocating for the needs of people in humanitarian settings, which can be done, for example, you know, for trainees, as the Global Health Committee at the RCOG, and there's similar, I'm sure, with many of the other colleges. And that's what I did to sort of fulfill my ambitions whilst I continued to be in the UK in my training. But actually, I want to come back to your comment about, you know, people coming out the other end of their career, because my so as I mentioned, my other job is I'm the specialist advisor for obstetrics and gynecology for Médecins Sans Frontières, and part of that role is identifying the international obstetricians and gynecologists that we really need to support us in our field activities. And I think it's quite a common misconception. People think you need to be sort of young and gung-ho and ready to jump into the field. And actually that's not what we need. What we need is experience. We have in Afghanistan, in Yemen, in Sierra Leone, you know, the places where we're working, we have local doctors and local clinicians who can provide a lot of the clinical care. What they need is experienced providers who can teach them and mentor them on the other stuff that we don't often think about in the humanitarian sector, such as all the clinical governance activities that go along with care, and quality improvement and finesse. You know, it's all very well knowing how to do a C-section, but, you know, really knowing how to manage the patient to avoid the C-section is much more complex.
Right.
And so actually we really want, and you know, sort of a bit of a call out for experienced obstetricians and gynecologists who maybe are coming to the later part of their career who would be interested in field work, because the skills of experience are what we really value and need, actually.
That's really interesting, because I was thinking, as you were saying, experience. When you arrive and you start to read the book about the day-to-day, so just putting Ebola and infectious diseases to one side, just the day-to-day obstetrics, I was really taken by the fact that you were seeing almost a ruptured uterus a day, an eclamptic fit a day or more. And I might see a ruptured uterus maybe once or twice a year, an eclamptic fit once or twice a year. So I also started to question whether my experience was actually terribly relevant, because it's a very different beast in a country without the degree of healthcare that we have in the UK. But so you explaining that about governance and finesse and the other stuff actually makes perfect sense, because I'm sure that the doctors you have on the ground are much better placed to deal with a ruptured uterus than I am, because they will have seen far more.
Yeah. I mean, I have absolutely no doubt that my local colleagues are much, much better at performing an obstetric hysterectomy than I will be, because they're doing it, a couple of times a month, if not more, particularly, some of the countries you work in. So, for example, in countries like Yemen and Afghanistan, where there's easy access to oxytocin and misoprostol in the market, we see a lot of ruptured uteruses, and a significant proportion of them will end up in hysterectomy. So what I often find is that, everyone always expects there's sort of this false perception that the international worker goes out and teaches the local staff everything, and that's totally not what happens. When it comes to the clinical work, as you said, it's almost like a different specialty, and it really is bi-directional experience, because as the international worker, there's so much that you're going to absorb from your local colleagues, because they have seen it all before, but it might be very new.
Yes.
Someone coming from a high income setting.
Now, I like that idea of bi-directional learning, and that sort of fits with, in your introduction, you talk a bit about not wanting to be seen as, in inverted commas, white saviour. And so, again, that kind of fits with that you can bring something to the people there and they can bring something back to you, and that collaboration, that really makes sense.
Yeah, absolutely. And I think, thanks for mentioning this, sort of what I've sort of put in the introduction about the white savior complex. I think that it's really important that we talk about the power dynamics within the humanitarian sector. We live in an age where we are really reckoning with the history of humanitarian action as almost in some ways, people talk about it as a relic from the days of colonization. This idea that it's, flying in people from high income countries to tell the local staff what they should be doing. And that really is not the case and should not be the case. And our role should be much more about plugging gaps, facilitating, and providing the tools for the local staff to be able to do the work that they need to do, because most of the time they will be the first responders. They will be the ones who are there when the conflict starts. They'll be the ones there when the earthquake happens. And they're the ones who know their communities and understand the needs of their community and how to speak with their community so that they know how and where to access services. And the depth of their knowledge are always going to be so much greater than what we can provide as people flying in. What we can provide are resources, but absolutely we're not in a position to be taking over.
Yes. And I felt that was a really clear theme through the book, actually. So perhaps if we turn to the book a little bit at the beginning and kind of start with your journey, you're arriving in Sierra Leone, and you get there, and even before Ebola is relevant where you're working, I was really struck by the welcome you had of, hand wash, disinfectant. I mean, it just felt very different to anything prior to the pandemic that we'd ever experienced in the UK. So I'm just wondering how you felt, because I mean, that seemed like culture shock, not in terms of culture shock of being in a different country, but culture shock in terms of totally different practice of medicine.
Yeah, it was an odd time. I mean, there was a few things going on. There was So prior to Ebola, there was, and there still is, endemic Lassa fever, which is another viral
Yes.
hemorrhagic fever that exists within that part of Sierra Leone. And so there were already quite strict infection control measures in place, which included this washing hands and heating food before you can eat it. If you bought food on the street, you'd have to heat it first to make sure that you weren't at risk of becoming ill, not necessarily ill with Lassa fever, but ill with something that might mimic Lassa fever and then cause concern and needing to be evacuated off to, I don't know, the Royal Free or something.
Yeah.
And so Ebola just, intensified those measures. And as you say, yeah, I wasn't expecting it. I was expecting the Lassa fever infection control measures, but I wasn't expecting it to be as intense as it was, particularly because, as you'll know from the book, before I got to Sierra Leone, although the outbreak had started, the general feeling was this wasn't going to be something which was going to, run through the whole country and through the region. This was something which was very much in the border. It was concerning, but it wasn't concerning to what I was going to Sierra Leone for. But that very quickly changed.
And I think in that sort of early bit of the book, I really felt that dilemma between what is an infectious disease versus what is normal pregnancy or pregnancy pathology even.
Yeah.
And I did recognize that from what we experienced with COVID, that as soon as anyone had a temperature, people were suddenly going, oh, she could have COVID, in the days before we were able to test. And I'd be going, oh, I think this is probably just a normal urinary tract infection or postnatal endometritis, an infection of the lining of the womb. And that real difficulty of, if you treat a COVID or Ebola case as a normal pregnancy thing, then the potential damage you can do, but also women needlessly suffering and being unwell or dying from a normal pregnancy complication because you've assumed it's the infectious disease. So that must have been really difficult.
Yeah, no, absolutely. And there was a lot that I took from my experiences with the Ebola outbreak and working with maternity and obstetric cases that I pulled over to COVID at the beginning of the pandemic, but very similar to as you describe. And, I feel that it's very easy for us to slip into this tunnel vision, that everything becomes about the infectious disease, and we quite quickly forget our basics really of medicine, which is taking a history and doing an examination, which, I remember very clearly at the early part of the pandemic, I say anyone with a cough immediately was COVID, and people would be panicking and wanting to isolate and before they stop to take any history, does the person have asthma? Is this a cough that they've had for 2 years, 3 years? Are there any other symptoms suggestive? Have they had listened to the lungs? Have they checked to see if they're clinically stable? And this is a real danger in these situations. Particularly, I think what was quite unique for Ebola is that it's transmitted through body fluids. And of course, childbirth has a lot of body fluids.
Yes, completely.
And that sort of added an extra element of complexity for us, but also that the symptoms, that make up the case definition, so what we use to decide whether or not someone meets the criteria for Ebola or viral hemorrhagic fevers, that list of symptoms is basically your list of symptoms of people coming with maternity complications. It is going to, is it fever, it's bleeding, it's abdominal pain, exhaustion, intrauterine fetal death or miscarriage, stillbirth. These are all sort of your big red lights shining, saying, be careful, beware, consider moving this person into an isolation facility, putting on this the full PPE, which in the cases of Ebola is the full bodysuit, and really restricting your invasive measures, which rules out pretty much all of obstetrics,
Yes.
which is a big call to make if that person also is in labour, and without taking good history, you might be missing that actually the reason why she has a fever and a stillbirth is because this is a labour that's been obstructed for 3 days,
Yes.
which can happen in some of these settings where there's very poor
Yes.
access to healthcare from the outset.
Yes. You really brought through in the writing these impossible choices, really. It really came through to me. The other thing was your description of the PPE, the full body suit, but the full body suit in that climate. So almost like you were drowning within your bodysuit because you were sweating and hot and stifling.
Yeah.
And that additional challenge that brought of how long you could spend in it, and therefore how long you could give care, because you got to rehydrate yourself frantically the whole time.
Yeah. I mean, it was unbelievable, the temperature inside those suits. There'd be so much sweat that you take your boots off at the end and you'd be able to pour the sweat out of your boots. Or the goggles. I think I sort of wrote about it in the book a little bit that, I'd have to have my head tilted to one side if I was doing surgery. There'd be so much sweat inside my goggles that it would be filling up. It wouldn't just be that it was a few drops dribbling around. It'd be like in a swimming pool. It was incredibly intense. And I'd say that once I'd been engaged in the response for several months, there was I was offered this opportunity to stay longer. So most people who work in Ebola responses go for about 6 weeks and then come out to get a break. And just by course of what happened with me, I ended up staying for a much longer time. And I kept being asked, would I stay longer? And at one point I said, I'll stay longer, but I just can't wear PPE anymore. I need a break from this ridiculous heat and sweat.
Yes.
It was a trauma in its own right, let's say. A different type of trauma, but certainly traumatic.
Yeah, no, that really came through. No, and I was interested in this idea of 6 weeks, or, as you say, you stayed much longer, and how you wrote in the book about the workers from the local population who obviously they can't step away. That is their life. That's what's happening in their village, regardless of whether they're working or not working, they're surrounded by it. And the very different experience, I guess, of being able to walk away and have a break of some kind versus not. But I loved your descriptions. They're talking about the not PPE, the descriptions of kind of your clinic through the fence, sort of. That was very kind of very practical way of dealing with things. But again, something that, we just wouldn't have contemplated. And having been through COVID, got a small chink of what that might be like, but very different.
Yeah, but I think, sort of that experience, as I said, a lot of these experiences I took with me for COVID, but I also took with me for future Ebola outbreaks, which I've supported with. And one of those things is the importance of comfort. And I think that it's massively overlooked by people maybe who don't have the direct experience so much of how important it is for healthcare workers to be comfortable in their place of work. So safe is one thing, but they sort of go hand in hand. And so, if I'm being told that I should be doing all my surgeries in full PPE because that's the safest thing, but then I'm so hot, I think I'm going to faint. I can't see through my glasses, my goggles, because they're full of sweat. I can't feel the ends of my fingers because my 2 pairs of gloves are far too big for me. And, there's a risk that scalpel's going to go into my finger, or I'm going to have a needle stick injury. The operation is going to take me twice as long as it would do if I was wearing half the amount of protective equipment. There's a point where I feel that we become less safe. And now, I when I speak to different organizations about Ebola response and particularly the continuation of normal health services, which is this huge section of an outbreak response that everyone seems to put, at the bottom of the list, although I think probably it should be near to the top, is the importance that you're able to continue providing that care as practically and as safe as possible. And sometimes that means, I think, with PPE, that less is actually safer. And I think that was true for COVID as well in some respects.
Yes. No, I agree. And I do remember, I didn't know who you were at that point, but I do remember during the outbreak seeing some of your tweets about, guys, you're going to need to practice taking on and off the PPE and operating in the PPE. And this is what it's going to be like. And me thinking, oh, okay, I hadn't even thought about this. So I think some of that wisdom came through, definitely. So you were talking just then about comfort. And one of the bits in the book that really grabbed me was, and again, this happened in COVID, the mother with her 2 children, and the fact that the 2 children needed to go into the Ebola section and she didn't. And having to explain to her that she couldn't go in with her children and that she had to trust you to look after the children, and knowing that they may or may not survive. And that seemed very similar to some of the things we experienced in COVID, of people not being able to see their loved ones and not being able to say goodbye to their loved ones. But I loved the fact that you spoke about the other recovering Ebola patients caring for those children. It was very powerful, that human element of that story, I think.
Yeah, I think, this issue with someone has an infectious disease, they need to be cared for in a hospital, and we're going to have our different isolation rules and PPE rules. And what does that mean for their rights as a patient, as a human, to have contact with their loved ones, and for their loved ones to have contact with them? And this was something which, I really held on to during from my experiences with Ebola. And one thing you might recall from the book is the 2 young brothers who, just for people who might, who haven't read the book. So I speak quite a lot about these 2 young brothers who are admitted into the Ebola treatment center. So later I start my journey working in obstetrics, and as the outbreak explodes, and it really does explode, I eventually end up working in the Ebola treatment centers, which are these large medical camps, essentially, on the border with Sierra Leone and Guinea, filled with people with Ebola and a staggeringly high death rate. They were very important places. They saved a lot of lives, but they were difficult places to work. And one of the key core differences between Ebola and COVID was that Ebola really was fatal for anyone, regardless of their age, of their gender. And, the mortality rate, particularly at the beginning of the outbreak, was somewhere around the 70% mark, maybe a little bit higher. Yes. It came lower, but certainly at the beginning part. And that included young children, adults, and with full strength, as well as the elderly. And so, as Florence said, if children tested positive, but their parents hadn't, or if their parents had already died, which was often the case, they would be admitted on their own. And then we would be caring for them, but with all those limitations that came with the PPE and isolation. And these 2 young brothers are just 2 patients out of many, many, many patients that I looked after over the course of that period, who I, in some ways, almost, wrote the book for, because I made a promise to myself that I would document what I was seeing, not only the impact it was having on maternal and reproductive health, but what was happening to a whole generation of people living in that area at the time. But one of the things that I took away from this was that if people fear coming to their health facilities, if they think, if I get admitted to that Ebola treatment center, I will not be able to see any of my loved ones. Or if I'm a loved one and I think that my child has got Ebola, and I think if they go there, I'm not going to see them, and there's a reasonable chance they're going to die, then the likelihood of me taking them to that treatment center is so low.
Yes.
And so this is something which I really took to heart, and we made changes with Ebola. We found ways to make sure that relatives could see one another, whether that was over the fence, which was the sort of visiting area, and in later epidemics, through redesigning the way that Ebola treatment centers work. But with COVID, my interpretation of this was with birth partners and the discussion around pregnant women coming, or pregnant women and pregnant people coming into hospital during the pandemic, regardless of whether they've got COVID or not, and not having a chosen support person alongside them. And I felt that this was something which should never have happened. And I know that a lot of people feel very strongly about it, and there was a lot of different opinions. But certainly where I worked, right from the outset, I shared my experiences from Ebola and said, look, if we want our pregnant patients to come early when they've got complications, to access our services, to feel that these are still appealing services and welcoming services, they've got to know that they can have someone with them. Because I felt there was a real danger that we would have much later presentations where people waited longer because they were scared to be on their own. And I think that, I don't know how the COVID inquiry will pan out. I don't think any of us do. But I do hope that this is one of the reflections that comes, is the, I'd say almost the lack of humanity when it came to how we treated people coming into hospitals. And actually, not just pregnancy care, but I include people who are admitted into ITU, people who are admitted onto the COVID wards. I just never understood why a face mask was good enough for me to be on the COVID ward with people, but not good enough for their wife or their son or daughter. And I never will understand that.
Yes, I completely agree with you. And I'm definitely seeing some of the aftermath of that now that we're, a couple of years on. Some people coming back for another pregnancy, finding it almost re-traumatizing, the fact that they can have someone with them now and what they missed last time, or very difficult memories, or struggling to believe that they will be allowed to have someone with them because they weren't before. So I think that's very true. I think with the Ebola Treatment Centre, it really came through the desperation of there being very little that you could offer those patients initially. And like you say, almost if I present, then it's almost like a death sentence. I mean, I don't want to spoil the book, but there's a bit where one of your colleagues becomes unwell, and it's that feeling of dread of, I know if I say, yes, actually, I have got some symptoms, this is what's going to happen to me. And just how devastating a disease it is, and how you keep the humanity and the kindness within such a devastating illness is really tricky balance, isn't it?
Yeah. I mean, I think that we learned a lot through that experience. I think also, there was as much as there was a lot of sadness. You mentioned the patients that recovered, and that there was, a huge amount of joy with every person that survived and was discharged, and the messages that they carried, which was, when it comes to community engagement, there's no stronger message than someone who's had an illness surviving and going back to their village and being able to speak about that than anything I or any other healthcare worker is going to be able to say. And, we saw that again in COVID,
Yes.
the messaging needs to come from people from the community and needs to come from credible voices. Boris Johnson on the 6 o'clock news or whatever doesn't necessarily speak to huge chunks of our society.
Yes.
And so, there was a lot of joy. Despite the horror, there was a lot of joy in those discharges and in our wins. And some of those wins were the finding ways to help pregnant women who had Ebola survive that course, because at the beginning of the epidemic in 2014, the thinking was that about 90% of pregnant women will die if they get Ebola, and 100% of their babies will die. And we found ways to dramatically reduce that mortality rate through really, really quite simple measures, actually. And by the end of the epidemic, the mortality rate, so the death rate for a pregnant woman, was the same as it would be for a woman of the same age who wasn't pregnant, who had Ebola. And that was about 50-50. Still too high, still staggering, but a lot better than 90%.
Yes. Just thinking about learning for a moment, because I was kind of struck in the book about what you were saying about you'd learnt a lot from Ebola. And then COVID came, and it's almost like you couldn't, or it seemed like you couldn't get sometimes people to appreciate and understand that you had this learning that could be applicable to the current situation we were in, but they wouldn't listen to you. Like, I think you gave an example of staff wearing too much PPE, and just by complete coincidence, there's another Ebola outbreak just starting in Uganda, isn't there? That's do you think that we do learn? I think I'm struck by there's that thing in risk management about the organisation with a memory. And it's almost like in global healthcare, do we have a memory? Like, because actually we don't need to keep relearning and relearning. How can we make sure that we do actually learn and put into practice some of the things that we've learned so we don't make the same mistakes over again?
Well, I think we're living it right now. As recording this in October, we're heading into winter, and we know that there's another wave of COVID. We know there's going to be a lot of flu and other respiratory viruses. So I'd ask myself, standing where I am right now, do I feel that life looks really different to how it looked in February 2020? Can I get a test? Can I find out if my patients or my friends or family have been unwell? Can they access a test? What are the current rules and regulations around managing a COVID-19 outbreak in this coming winter? Have I been offered my vaccine yet? Has everyone else been offered the opportunity for a vaccine? What is the communication that we're getting from our leaders? And by leaders, I mean not only our politicians, but our community leaders. And is it speaking across the community to all aspects, all languages, all ethnicities? If the answer to those questions is no, then I would say it's questionable if we have learned.
Yes.
And I think that, in global health, we, and probably, I guess within the NHS as well, we speak a lot about lessons learned, but I think I write this in the book as well, I would say it's more about, we're good at identifying lessons. We're good at holding our hands up and saying, oh, we didn't get it right.
Yeah.
But this is what we should have done. But when it comes round again, we're not always that good at implementing those lessons that we identified before. And so, as you mentioned, there is another outbreak that's been declared in Uganda of Ebola. It started just over 2 weeks ago. It's quite widespread geographically, and it's certainly concerning. There's definitely some lessons that have been learned that are coming through. Much quicker mobilization, much quicker recognition of the severity and the spread and the risks. And the testing turnaround is much quicker than it was for us during the first Ebola outbreak. It takes about 6 hours to get an Ebola result now in Uganda, whereas for us at the beginning of the West African outbreak, it was taking up to about 48 hours, sometimes longer.
Yes.
But we can all relate to that from COVID. You remember how long it took to get a COVID test, if you could get one. In March 2020. And I was pulling my hair out because I was thinking, we know this is nothing new here. We know that a fundamental foundation to getting a grip on this epidemic, to be pandemic, is knowing who has the virus.
Yes.
And our government was telling us, you only need to be tested if you've arrived from Wuhan, Thailand, or northern Italy. And it was very clear that there was COVID all around us. And actually, I remember when COVID began, I had just come back from Sierra Leone, where I'd been at the beginning of 2020, and there was a Lassa fever outbreak. And I'd just come back, and I was doing some ward rounds, and there was clearly patients who met the case, what would be the case definition for COVID, but we were not allowed to test them. And at the same time, my boss for the work I'd just done in Sierra Leone, she was an epidemiologist in Australia. So this was in March 2020, and she called me and she said, "Listen, have you got community transmission of COVID in London?" And I said, "Well, not officially, because we can't test people if we think they had it in the community. So no, officially no, but if you're asking my opinion, I think it's everywhere." She said, "Well, that's interesting because nearly all of our people who are testing positive in Australia are people who have some link to passing through a London airport."
Oh, wow.
So, I have no doubts that our government's reticence and slowness to accept what was happening, and whether or not that was to do with other political events happening at that time. If you remember, it was also around the Brexit negotiations and all the rest of it. Whether or not they had a false economy where they thought, well, if we just bury our heads in the sand a little bit longer, it'll be okay. And clearly it wasn't. And I do question whether or not we're witnessing our government burying their heads in the sand again as we head into this winter. But let's see.
I wanted to just turn for a moment to kind of the collateral damage, as it were. So towards the end of the book, you focus much more on actually, if we're in the middle of an epidemic, which has such a high mortality for pregnant women, and also lack of ability for those pregnant women to access the healthcare they might normally potentially be able to get, that we should be thinking about contraception.
Yes.
And the idea that an epidemic or a pandemic has this terrific knock-on effect on other health, and like you say, the response doesn't focus on that kind of preventative stuff. I mean, to some extent, we're seeing it with COVID as well, aren't we? Things like undiagnosed cancers and long waiting times for surgery and so on. So perhaps you could talk a little bit about that, because I feel like you kind of part the way through, it's like almost you had this moment where you suddenly thought some of this could be prevented and you kind of shifted in what you were trying to achieve.
Yeah, I mean, I think the first thing really is that, look, contraception is absolutely not a replacement for accessible and good quality maternity services. What happened for us in the Ebola outbreak is that we were not able to offer at that time, despite our motivation and will, we were not able to offer accessible and high quality obstetric services. And so as you say, the conversation moved towards, well, if we know that the mortality rate from being a pregnant woman in Sierra Leone at the time of this outbreak, so it was estimated at the peak of the Ebola epidemic in Sierra Leone, that if you're a pregnant woman, not with Ebola, just a pregnant woman, you had a 1 in 7 chance of dying from pregnancy-related causes, right? Now that estimate didn't come to bear, but that's what we were being, that was what the UNFPA, which is the United Nations Populations Fund, were saying. And so, pregnancy is a life-threatening condition. And so really, we felt that myself and my colleagues, that if we couldn't provide them the care when they're pregnant, we should at least be making sure that they have the opportunity to choose whether or not they want to be pregnant.
Yes.
And that's where this access to contraceptive services came in. But the truth is, it shouldn't take an Ebola epidemic to make sure that there's universal access to contraception.
Oh, totally.
And if we just look at the data from this year, look, we know that globally over 50% of the world's pregnancies are unintended. And we know that of that 50%, 65% of them will end up in an abortion. And of that number of abortions, 45% of those abortions will be done in an unsafe way. Right. And that is already one of our leading causes of maternal death in the world. So it doesn't take a genius to work out that if we could make sure that contraception and education around contraception and knowing how and when to choose to get pregnant was available to everybody, would dramatically reduce the morbidity and the deaths for women and girls and pregnant people. And it shouldn't. So I got my soapbox a bit, but it shouldn't be in the hands of just midwives, obstetricians, gynecologists, GPs. This is something which should be accessible at least in my opinion, this is something which should be accessible in every place where people of reproductive age access healthcare.
Yes.
So, this should be, all those pediatric wards, and in the humanitarian setting, all those malnutrition refeeding centers.
Yes.
Where you've got all these, babies, children there, and their mothers are sat next to them.
Yes.
Those women need access to contraception if they choose it. It's an option, but if you don't give the option, they don't have it. And during COVID, we had that discussion, women coming to pediatric outpatient consultations in hospital with their children, should they know that whilst they're here, if you want to discuss contraception or get your pill or, talk about the options available, then this is an opportunity to do it. And I think it's something which we just haven't quite integrated fully into what we offer.
Yes. No, I think that's a really good point. I feel like we're coming towards the end. I'd love you to explain the title Belly Woman, because I loved that bit, because I picked it up and I thought, oh, that's an interesting title. And then it came through in the book. So why is the book called Belly Woman?
Sure. So I should start off by saying Belly Woman is a made-up title, made up by me. However, in Creole, which is one of the languages in Sierra Leone, the name for a pregnant woman is Belle Yoman, which Creole is a mixed obviously of English, which sounds very similar to belly woman. And actually, pregnancy is considered belle. A woman got belly. She's got pregnancy. And so, and actually, I was referred to in the Ebola treatment centers as the Belle Yeoman doctor.
Right.
And so I felt that if I were to just anglicize this title a little bit and make it Belly Woman, it gave that link to the Creole and a link to my journey. But also I felt that visually, it gives a really interesting visualization of what this book is about. And obviously it works very well for anyone who sees the book, they'll see that it's very clear what the book's about from the image on the front alongside the title.
Yeah, I love the title. I thought it was great. Finally, if you were to think of a zesty bit, what would you like midwives, doctors, women listening to this to kind of take away? What would it be, do you think?
Well, aside from, recommending that they read my book.
Oh, of course. Yes. Actually, seriously, that would be my zesty bit. Go away and read the book, because I thoroughly enjoyed it. I mean, we've talked about the fact that not sure it's an enjoyable reading about an Ebola epidemic, but it is absolutely fascinating. If you're working in maternity and you want a different view on life, it's absolutely gripping. And I do highly recommend it. So that's my zesty bit.
I think my zesty bit would be think about your community, actually. I think, when you, at least for myself, when I reflect on not only the Ebola epidemic, but also on all of the humanitarian work that I've done around the world, and also my work in the UK, when it comes down to having health services that work, it comes down to the community that you're working with, listening to what they want, listening to what they tell us. There's this approach that we sometimes use called radical listening, which is sort of a step further than active listening. It's just going with an open mind and hearing what people have to say and taking it at face value. And I think that more and more as health providers, particularly in reproductive health and maternal health, we need to listen to what the communities we work with tell us they want and what they need to be able to deliver a service which is appealing and acceptable for them. So that would be my, I don't know if that's zesty enough.
I think that's really good, actually, because I'm also thinking that is so applicable to everywhere, whatever setting you're working in, listening really properly to what people need and want it's critical. It's the foundation of everything, isn't it? And I think that you're right, that comes through with Ebola. Are people going to trust you to say they've got symptoms and come for care, right through to, in this country, maternity voice partnerships, and are they going to come and access maternity care and book before 10 weeks? It's the same principle, isn't it? So I think that's an excellent zesty bit.
Thank you.
Thank you very much. Good luck with the book launch. It's been an absolute pleasure to talk to you.
Thank you.
I very much hope you found this episode of the theobspod interesting. If you have, it'd be fantastic if you could subscribe, rate and review on whatever platform you find your podcasts, as well as recommending the theobspod to anyone you think might find it interesting. There's also tons of episodes to explore in my back catalogue, from clinical topics, my career and journey as an obstetrician, and life in the NHS more generally. I'd like to assure women I care for that I take confidentiality very seriously and take great care not to use any patient identifiable information unless I have expressly asked the permission of the person involved, on that rare occasion when it's been absolutely necessary. If you found this episode interesting and want to explore the subject a little more deeply, don't forget to take a look at the programme notes where I've attached some links. If you want to get in touch to suggest topics for future episodes, you can find me at theobspod on Twitter and Instagram, and you can email me theobspod@gmail.com. Thank you for listening.